Sorry about that. I'll be speaking on lens-based refractive surgery. Why are we getting interested in this and this basis of refractive surgery gaining traction? Is because we are getting far more accurate with biometry, both as far as the availability of optical biometers and the modern formula that are concerned. The availability of premium trifocal EDOF lenses, toric lenses, which allows us to gain good quality as well as quantity of vision, excellent post-surgical visual outcomes, and the fact that people in their 50s and 60s also want to enjoy sports, enjoy a spectacle-free vision, and that is something that we need to address. And obviously today, the indications for lens removal could be considered as cataract, high emetropia, and treatment as presbyopia. This could have been considered as sacrilegious and unethical just less than a decade back. Today again, I would choose my patients. It's not that I would do it for a high myopic patient, but then in case there is a high hyperopia, then these are the patients who will benefit from it. And we also must understand that though we might not be seeing a cataract on the slit lamp, these patients might be having a dysfunctional lens. So as you can see here, the same patient at the age of 25, at the age of 55, you can see that both these lenses appear quite transparent and clear, and maybe with some refractive correction, the patient might be having a 6/6 N6 vision even at the age of 55. But then at this age, there is a significant increase in the spherical aberration and light scattering of this lens. There's a significant increase in lens thickening, refractive index of this lens, and the transparency and the accommodation of power of this lens is obviously less. So obviously, just because the lens is clear, you cannot consider it as functioning optimally, and that's why the concept of lens dysfunction came into being. Just to show this, you can see this slide over here, and this is the normal lens of a 25-year-old, this is of a 55-year-old. Obviously, this is a much thicker lens, and the point spread function of this lens would also be much worse. And as we are all very familiar with, the accommodation drops down from almost 12 diopters when the patient is 10 years old to almost nil when the patient is 60 years old. Obviously, so you need glasses for reading. Then there is a loss in contrast, the modulation transfer function, the point spread function, everything deteriorates in these lenses, and hence the need for a better optical system in the eye rather than the natural lens with which the patient was born with. And this can also be quantified by using an eye trace, and apart from various other data that you could get, you can also measure this lens with dysfunctional index, and anything above 5 or above, closer to 10, in a younger patient you will get it close to 10. Anything above less than 5 is considered as a somewhat dysfunctional lens. This is from the internal, from the cornea, which looks pristine. This is the aberrations from the internal optics, and this is the total optics of the eye. So obviously, if you are able to replace this internal optics of the eye, which is dysfunctional, this is the kind of picture that you might end up with. Here again, it's just an aspheric single piece which has been implanted, but you could find that there is a significant improvement as far as the quality of vision is concerned. So the dysfunctional index is nothing else but an objective measure of the internal aberrations, the contrast sensitivity, takes into consideration the pupil dynamics, because larger the mesopic pupillary size, the more is the impact of the optical aberrations. So though the lens might be clear on the slit lamp, it might be acting like a cataract, and obviously if that's concomitant with a significant hyperopia, replacing the lens would be advantageous to the patient. Before doing this, obviously you would have a good look at the aberrations. These are the internal aberrations, and this is from the cornea, and this is a pristine cornea. So obviously if you are going to take care of the lens and remove it and replace it, the patient is going to be left behind with just the corneal aberration, which seems to be minimal, and that's a good quality of vision. On the other hand, if you come across a situation like this, where there is a significant amount of corneal aberrations, that might be, you might consider, or at least forewarn the patient that subsequent to the surgery, the kind of optical aberration, dysphotopsia, especially if you are placing a multifocal intraocular lens or a trifocal lens, might be quite significant. There used to be a lot of talk about angle alpha, angle kappa, angle alpha being more relevant to cataract surgery and kappa to laser vision correction. But today experience has told us that angle alpha is not that important. Earlier I used to consider anything beyond 0.5 millimeters as a relative contraindication. You very rarely come across patients with angle alpha of more than 0.5 millimeters, and today even if it's up to 0.7 millimeters, I would go ahead and implant a trifocal lens or a multifocal lens, provided there are no other contraindications. So obviously when you are dealing with a hyperopic eye and do a lens extraction, you are also taking care of a shallow AC, the propensity for angle closure, and unlike in highly myopic eyes, the increased risk of RD, CME, CNVM, etc. is not there in these eyes. And unlike in laser vision correction, you would also be minimally inducing higher order aberration so that the quality of vision is well maintained. Obviously, if you are treating eyes with high hyperopia, there are greater chance of choroidal effusion, and that's something we need to keep in mind while taking up these patients. So accurate biometry is extremely important, and immersion biometry by a very experienced optometrist is also good enough. Otherwise, if you have access to one of these modern day optical biometers, that would be the way to go in conjunction with a modern day formula. Again, another point you need to remember is that compared to the velocity of sound especially, this may not make much of a difference if you are doing a laser interference biometry or a strepsils biometry. But if it is an acoustic velocity, it might differ between a clear lens and a cataract test lens, because of which the formula might end up giving us a plus 0.5 or a plus 0.75 hyperopia. So if you're doing a prelex, it might be a good idea to go ahead and induce a minus 0.5 diopters of residual error. So usually when you're doing a prelex, then you have to do it bilaterally. It's a astigmatically neutral incision. We know that most of the incisions of sub 2.4 millimeters cause just about 0.1 diopters of surgically induced astigmatism. In the bag implantation with excellent centration and using lenses which are not prone for posterior capsular opacification and are very well intact endothelium even post-surgically or all the basic tenets what we observe in good phacoemulsification or laser cataract surgery is extremely important. Just in case you have a situation where residual error is there, subsequent to this, again you have promised these patients refractive accuracy. Of course, you would be always telling that there could be an occasional need for glasses. But if it does come up, as you can see in these couple of eyes with the intraocular lens implant in, then you can always do a laser touch-up. And very often, because these patients have small residual errors, doing a transepithelial PRK itself is good enough and the results are quite good. Of course, if there is a larger residual error, especially after primary lens implantation, you could also do a piggyback lenses. This technology has not become available to us, but obviously this is developing, drawing considerable traction in the West. The light adjustable intraocular lenses, where you can place a lens and then subsequent to the comfort level of the patient, maybe in a couple of weeks' time, maybe after bilateral surgery, you can either touch up one eye or the other to correct astigmatism, induce multifocality, even take care of aberrations, so that post-operatively, depending on the patient's visual results and visual expectations, you can titrate the kind of power or the various other features of the lens that you leave behind in the eye. Obviously, even if I am asked today, what exactly is the type of lens that you want when you have your cataract surgery, I am a little in doubt in spite of the fact that we have been doing cataract surgery for so many years. So, if you can give the patient the choice to titrate the kind of lens they want, subsequent to the implantation, that would be a great way to go. Let's see if this comes up in our professional lifetime in our practice. So, I do believe that the greatest catalyst for interest in prelex is the development of multifocal and multifocal toric intraocular lenses, and today it's mostly trifocal lenses. But obviously there are several disadvantages and not to be taken lightly, and it's whatever complication of invasive surgery and intraocular surgery, even a remote complication of endophthalmitis, posterior capsular opacification, possible need for YAG capsulotomy, and that's the reason that you would not consider these in myopic patients, significant myopic patients. And the fact that you're replacing a 5 millimeter natural lens with a 1 millimeter artificial lens obviously gives the eye more space for the vitreous, the capsules to be more mobile, and then the remote chance of CME, retinal detachment, etc. Thank you so much for your kind attention.
Thank you, Ramamurthy, for this wonderful talk. So, finally, you think that it is only for correction of hyperopes rather than all refractive kind of corrections which you want to do. The refractive cataract surgery, you think that is the only indication in your practice?
As of now, I have done a couple of myopic patients, like, when one eye has already received an implant, other eye has some early lenticular sclerosis, still they are seeing 6, -2, -2.5, etc. But I would stay away from doing this in highly myopic patients. One of the main reason being that it's been shown that once you do even a cataract surgery, subsequent to that, the chance of retinal detachment increases in these patients almost by 8 times. But there is a caveat to that. If there is a complete posterior vitreous detachment, then the risk of retinal detachment may not be so high. But all said and done, refractive surgery is still a cosmetic surgery. So even if there is a mild chances of a serious complication like a retinal detachment, I would rather stay away from that. So my usual run-of-the-mill patients who go for prelex in my practice are those patients not requiring too much of night vision requirement. Obviously, if it's a 55-year-old who has to drive 10 kilometers back from work, I don't want him to suffer with this. So these are ladies in their 50s, 60s, or men who say that they don't have much visual requirement, but need 2.5 for distance and about 5 diopters for reading. So they are the real happy patients.
Okay, because I might have done few hundreds of high myopes in the younger, age, in the age group of 25 to 35, and with IOL implant, with CTR, prior retina management, whatever if there was required, and then following it up for last many years, maybe 30 years plus. And the incidence of detachment in all these cases is not as high. It might be nearly 2 times as much as a normal if you leave them alone in a very high myopes. And the second indication in my cases was wherever there was a very high myopia, especially in all those very high myopia along with astigmatism. So in those cases, astigmatism, management of astigmatism was something which I thought was very important. And also bioptics in many cases where I did, like you also showed couple of cases of LASIK post-cataract and PRK post-cataract. So all these cases also I have done and done successfully, reasonably well, without many complications like endophthalmitis. Endophthalmitis is again a complication.
Is a very rare
complication. Very rare.
Yeah.
So that is why I said that I have personally done many and not burnt my fingers with that.
No, you have been fortunate, and I think there are others also who claim that they have done for high myopia. But I personally, I think literature bears out the fact that the incidence of detachment is higher. And most of these myopic patients have reasonably good AC depth. You rarely come across a patient who has a compromised AC depth with a -12 diopters of refractive error. So these patients obviously are a good enough candidates of phakic intraocular lenses. Yeah. And subsequently, when they develop a cataract, you can of course exchange the.
That's right. But I think for a -12 or such patients, it's okay to do a phakic, intraocular lens. But I'm talking of patients who have higher myopia, even more than 12. And I have done a lot of them with astigmatism and very high myopes. Any comments?
So this question is regarding for hyperopic patients. Are there any conditions where you would definitely put a CTR in these patients?
Sorry?
A capsule tension ring. My intention of asking the question is, how do you fix the ELP, the lens position.
In hyperopic patients?
Yeah, I mean, if you are replacing a 5 millimeter thickness lens with a 1 millimeter, 1.5 millimeter thickness.
No, I think, because the modern Barrett formula, etc., takes into consideration the wide to wide, the AC depth, the lens thickness, apart from the axial length, it's already the ELP that they give is fairly accurate. And what you find is that except in cases like plus 15 or plus 16 diopters, in which case I just place a plus 40 diopters and then place a secondary lens, a piggyback lens to correct the residual refractive error.
So these
But
would
otherwise for plus 3, plus 4, etc.,
Right,
I find that these formulae work quite well.
So these would be all eyes with an axial length of more than 22.
Not necessarily. They could even be 20 or 19, etc. I think the Barrett works quite well. But I'm not saying I hit refractive accuracy in all these cases. That's the reason I showed that laser correction also. And if in case there's and usually if at all it's an error, if it's a minus error, then it's better because it's more easily treated with laser.
वो भी आ गया I think. I think we'll hurry up because Dr. Harbans is also here. So there are 3 talks. May I request Dr. Gopal Raju to kindly give his talk?